So welcome everyone to our department grand rounds today. As you can see, today is our Morbidity, Mortality, and Improvement Conference. And I'm really excited to introduce our speakers today. As you know, this conference gives an opportunity for our quality improvement team to highlight some of the great work that's been done to improve care in the Department of Medicine. And I think that this topic is something that many people will resonate with greatly. So that being said, I'm going to just share my screen and introduce our panel of presenters. So the title of our presentation today is High Stakes Paging, Partnering and Communication Optimization. So our panelist of presenters today includes our Quality Improvement Director for the Division of Hospital Medicine, Dr. Stephen Biederman. For those that don't know, Dr. Biederman is an assistant professor in the Division of Hospital Medicine here. He attended university at the University of Medicine, School of Medicine, where he completed his internal medicine residency and was inducted into the AOA Honor Society. Here at VCU, he joined the Division of Medicine in 2018, and then in 2020, joined as serving as a Quality and Safety Director for the Division of Hospital Medicine. His current interests include communication and safe transitions of care, but outside of his work, he stays up to date with a medical education podcast. He volunteers at Crossover Clinic, stays fit with doing CrossFit, and something that I'd never heard before, supping, something called stand-up paddleboarding. We also have, joining him on this talk, Alison Wilkins, one of our nurse practitioners that works in our hospital medicine service, who is a phenomenal nurse practitioner and really well-versed in this topic. Mallory Manriquez, our nurse manager on progressive care medicine on North 9. Again, a great collaborator in terms of quality improvement efforts. And Chrystina Schuler, a nurse on North 6. So that being said, I'm going to turn it over to our presenters.
Good afternoon, everyone, and thanks for the introduction, Georgia. Steve Biederman, the Quality and Safety Director for Hospital Medicine. And we're really excited to talk to you guys today about a topic that we think is highly relevant if you've ever sent or received a page, which I imagine many of the folks on this in this meeting today have done. You know, we have maybe a complicated relationship with our pager as a provider. As a medical student, you're so excited about the ability to hold that pager. And then you become a resident and you can't wait to pass the pager off. But the pager stays with you throughout throughout residency and into life as an attending. And it's a critical aspect of how we interact with each other. And I hope that you are convinced of that and this triggers some thoughts and ideas for you as you are listening to this presentation. So with that, the goals of any morbidity and mortality and improvement conference are to learn from medical errors, complications, and unanticipated outcomes. And really, we want to engage in a discussion surrounding a critical incident and diagnose systems errors rather than looking for guilty parties. We are hoping to increase the transparency surrounding the quality improvement efforts that we're undertaking. Some ground rules for any morbidity and mortality conference are that we want to avoid finger pointing or casting blame on people and try and put yourselves in the shoes of those who are involved in the case. We do maintain confidentiality and don't use any patient identifiers or provider identifiers for that matter. And then we're trying to think practically how we can fix the systems in which we operate to prevent adverse outcomes from happening in the future. So the objectives for today's talk are to, one, share why successful interdisciplinary communication is critical, to outline best practices when it comes to paging, and then we'll spend the bulk of our time describing some ongoing quality improvement efforts to improve outcomes. And as Georgia said, I'm really thrilled to be part of a multidisciplinary team here with APP and nursing representation to really tackle this as a group. So we'll start by sharing why interdisciplinary communication is critical. So here's our case. A 60-year-old male, history of class 3 obesity, coronary artery disease, diabetes, and hypertension, presents with acute hypoxic and hypercapnic respiratory failure from uncontrolled OSA, OHS, and an acute pulmonary embolism. I'm going to give you the end so you know where we're going with this case, but the adverse outcome here is a delay in the diagnosis of a left retroperitoneal bleed and left psoas muscle hematoma, and this resulted in respiratory failure and hypovolemic shock. In the aftermath of this adverse event, safety intelligence report was entered, and one aspect was, quote, the team attending did not come to bedside after multiple attempts to call. So let's look at this case and see what happened. So we have this 60-year-old man who's here with hypoxic respiratory failure, has a new pulmonary embolism. On day 1, he was intubated and admitted to the ICU, and he was placed on a heparin drip. On day 2, he was extubated in the morning and then transferred to hospital medicine at general level of care. On day 3, in the early afternoon, the patient sustained a fall, and the physician came to bedside and noted that the patient did not hit their head, and an exam did not show any areas of tenderness and bruising. The heparin drip was therefore continued. That evening, the heart rate was elevated now to 110, and the blood pressure had dropped some to 98/69. At 4:56 in the morning, hemoglobin came back at critically low at 6.7, down from 10.6 the morning prior. And then at 5 a.m., we see a page from the nurse to the physician saying, sepsis alert and patient has low BP, critical hemoglobin, RRT is at bedside, MAP is better, patient is well, please call. At 6:45, the lactate comes back critically high at 9.4. And then at 6:50, that heparin drip is suspended. At 6:53, the nurse pages physician, patient is not having any output and blood pressure is low, please advise. And then at 7:07, the nurse pages the physician, main 14, I changed all identifiers for the record. We don't have a 14th floor to my knowledge. RRT called, patient hypotensive, 80s/60s, heart rate 110, nurse and RRT are at the bedside. From there, things move pretty quickly. There is a level 1 CT that shows the left retroperitoneal bleed and the psoas muscle hematoma. Level 1 consults are placed to trauma surgery and ICU. The patient is subsequently intubated, started on pressors, and finally receives their first unit of blood at 10:52 in the morning. So to summarize this case, we had a medically complex patient who experienced a fall while on a heparin drip. At the time of the fall, there was low suspicion for trauma, but over the next 18 hours, the patient's lab work and clinical status indicated impending decompensation. On top of this, the nurse astutely and correctly recognized they had a worsening patient and attempted to escalate their concerns, paging the primary team without perceived adequate response. This resulted in the delay in diagnosis and treatment that resulted in harm. So let's take a closer look at the actual communication that occurred between this nurse who is advocating on behalf of the patient, who's trying to sound the alarms that this patient, there's something going on here. And let's look at what the communication actually was. So the physician received several pages that night from a concerned nurse. Now, I know we've got some nurses and some physicians on the call, and I want you to put yourself in the shoes of whatever you're not. So if you're a nurse, try and imagine yourself as a physician who's cross-covering 60 patients and doing admissions in the emergency room. If you're a physician, try and think of yourself in the shoes of this nurse who's really invested in this patient, who sees something going wrong and is trying to raise the alarm. Let me also say that I spent maybe 2 hours on PowerPoint making this graphic to look like a pager. So I don't know, maybe I did have a disclosure. If you need any design work, this is the extent of what I've got for you. All right, so I'm gonna just read the actual text of the page. And as you can see here, all identifiers have been removed. Like I said, I know there are maybe a nurse named Tiffany, no relation to anyone in the real world, no phone number, etc. This is completely anonymous. So this is the actual text of the page. Patient pulled out his IV, which took a long time to get again. He is very restless and impulsive, trying to get out of bed all night long. I've been sitting at his bedside and he's still very unsafe. He states he has to void, but he has a Foley. He does have blood in Foley, but he did pull on it earlier. Can I have an order for something to calm him down and an order to irrigate his Foley? Thanks, Tiffany. Second page at 5:03. Patient fired a sepsis alert and patient has low BPs, and he now has a critical hemoglobin called from the lab at 4:55. Our RT is at bedside assisting with a low blood pressure and sepsis alert. MAP is better. Patient is well. Please call and advise. Thanks. 6:52. Patient is not having any output and blood pressure is low. Patient has not really slept and he keeps saying he has to go to the bathroom. Tried to bladder scan, but he's very obese and hard to get. Please advise. Thanks, Tiffany. He has a critical lactate of 9.4 ABG. So in review of the case, we know that this nurse was astutely, correctly recognizing decompensating patient and was trying to get the physician to come to bedside. So what we asked, do these pages reflect the concern about the patient's actual acuity? So what you see here is a Fishbone diagram, which is a frequently used tool when we're looking at an adverse outcome, because we recognize that anytime we have something bad happen, there are multiple causes that lead to the effect. Typically, we have checks and balances in place to try and prevent bad things from happening, and most of the time we catch things. And so we recognize that for any adverse outcome, there's typically many different ways that we could have maybe righted the ship, course corrected before we experience that effect. And there's a lot of different aspects of this case that we could look at. We can look at the processes as a cause. What are the best practices for monitoring high-risk fall patients or high-risk patients after falls? We could look at factors of policies and procedures, the provider's response to the RRT, provider response to pages. We can look at teamwork factors. What was the handoff between the primary and covering physician that evening? Or was there a debrief between the nurse, RRT, and the primary team? There's monitoring factors. In this case, the night physician was covering around 60 patients plus completing ED admissions. And human factors, where there was a failure to recognize that this patient was on a heparin drip. But what we want to focus on for the point for today is really honing in on communication factors. In this case, we have a nurse that believes they are effectively communicating concerns, but there's a disconnect between that communication and the perceived response and what is received through their communications. So lest we think that this is an isolated incident, we know that communication factors are actually at or near the top of the most frequently identified root causes for sentinel events, according to the Joint Commission. And in fact, for the 2021 Hospital National Patient Safety Goals, which is a one-page document put out by the Joint Commission, several factors that are pertinent to this case are relevant. And we're going to touch on today: identifying patients appropriately, improving communication, and then management of patients who are high risk on anticoagulants. And unsurprisingly, VCU reflects these national trends, which highlight communication issues. You can see on the left in this graph that care communication issues are the #2 most frequently cited safety intelligence report for hospital medicine in the year 2020, or put another way, in the pie graph on the right, communication concerns in terms of safety intelligence reports are about 1/4 of our overall safety events. So we have a case where there was a communication mismatch, and we see that this is a national and an issue at VCU. But how do we communicate? Well, paging actually still remains the primary form of communication between physicians, APPs, and nurses outside of bedside rounds. This is a 2017 cross-sectional survey published in Journal of Hospital Medicine, where they really tried to elaborate further on what technologies are used to communicate about patient care. And then you can see the #1 used technology is paging, which was actually 80% of respondents had pagers that were available for them to use. And even though less of them would use it as their primary form of communication, it was still the #1. So hopefully you're convinced, if you weren't already, that interdisciplinary communication is critical. So now I'm excited to turn this over to Chrystina to talk to us about some best practices when it comes to paging.
Okay, I'm going to talk about the anatomy of a page. So there are five critical elements that VCU has identified that are needed to make a page successful. Those elements are priority label, the sender's name, a 7-digit callback number, patient's name and MRN, and concern. For examples on the right-hand column, there are examples such as a label of FYI or please come, the sender's name, the phone number, the patient's identification of name and MRN, and this concern example is a blood pressure of 200s over 110s with multiple readings. VCU has 2 documents explaining the paging escalation algorithms and best practices. The first document that I'm going to review is the algorithm for escalating care. This document can be found on the VCU intranet on the SharePoint sites under escalation and level of care guidelines, and it is available to everyone. This is a document that defines a sequential escalation of a team member's concerns. So basically starts off if a team member has a concern about a patient's clinical presentation, the first step is to page an intern when applicable. A response from that intern would be expected based off the appropriate priority label sent in the page. And if the clinical concerns were not resolved or no response is received, then the resident or APP is next page. And it is the same process to continue the escalation to then the attending physician, ending with the senior physician on call who can also be paged. The main takeaway from this algorithm is when you should escalate, and by using an appropriate priority label, that will set the tone for what type of response is expected from the team. The second part of that document gives additional information about priority labels. VCU has identified 4 different priority labels used to escalate care. The first one is FYI label, and that is used for sharing information that does not require a response unless the provider is changing the plan. An example of this would be shown below, like FYI Jane Doe, the patient refused DocuState because of loose stools. Another example of an FYI page would be, say the patient is back on the unit from an x-ray. The second label is the please verify and advise, when the person paging needs verification that information was received. An example of this would be the blood pressure is 176 over 94, 30 minutes after labetalol given. Another example of a please advise page would be the patient still nauseated after PRN Zofran given. The third label is please call, and the person paging needs to speak with the provider as soon as they are available. An example of this would be please call, blood pressure is 190 over 100 with dizziness. Another example of the please call page would be regarding critical lab results. The fourth label is please come urgent, and that is used to convey any acute changes that the provider is requested at the bedside as soon as possible with a call back immediately, or an immediate response is given with delegation to another clinician if they aren't able to be at the bedside. An example shown below is a please urgent page for an RRT call for blood pressure of 210 over 126. Other examples of please come urgent pages would be any RRT, any behavioral rapid response, or any patient decompensating. And these labels are used to identify the acuity of the pages being sent. The second document explaining the paging escalation algorithms and the best practices is the effective paging guidelines. For an effective paging guideline, we have a format example again of the priority label, your name, a 7-digit callback number, the patient's name, MRN, and the concern. This defines the 4 different priority labels. We have the FYI, which doesn't necessarily require a response unless the provider is changing the plan. For please verify and advise pages, we expect a callback within 30 minutes. For please call within 15 minutes, and the please come urgent pages have, they request an immediate response. And if the provider can't come to the bedside, then they are delegating to another clinician to come in their place. And again, these labels set the acuity and the response expectation of the pages that we are sending to the doctors. In an ideal state, each element would be present every time we send the page and written in the same order for continuity, which is again, the priority label, the sender's name, a 7-digit callback number, the patient's name and MRN for identification, and their concern. Another example below would be please advise Jerry RN, phone number 663-8482, patient Walker with their MRN, and the concern is a blood pressure of 210 over 105 on multiple readings. In this case, with the original page, a better use of an appropriate priority label might have made the page more clear. From my perspective as a nurse, I would think, how could I have simplified this message and relayed exactly what I was expecting from the doctor? So for example, if we didn't change the context of the nurse's page, but used a better priority label and a better use of the 5 critical elements needed, we could have possibly made it more simple with please call Tiffany with her phone number regarding the patient's identification and patient fired a sepsis alert, hypotensive, critical hemoglobin of 6.7, and RRT at the bedside. Another perspective is to also, as a nurse, trying to think of how you could escalate this appropriately and use another priority label such as please come to the bedside if an RRT is already in progress. And then back to Dr. Biederman.
So thanks, Chrystina. So hopefully what we've shared now with you, some of the best practices that, that VCU has when it comes to paging. And we're now going to talk about our ongoing quality improvement efforts to improve outcomes. So just a word about this and not going into too much detail, but when trying to tackle this problem, we wanted to use a framework. And in this case, we used the Lean Six Sigma framework, which is a methodology for approaching problems and problem solving. Lean and Six Sigma are two complementary different kind of techniques with which you can approach a problem. I think the tendency or the trap for any issue is to see a problem and then to immediately suggest, okay, let's just do a solution. And what this methodology does is it forces you to take a more holistic look at get a full perspective of what are the triggers that are leading to a consequence, and then how can we design the system to stop or to improve upon this process or to an adverse effect. So the tools that we use for Six Sigma is the DMAIC methodology, where the D stands for define. What is the problem that you're trying to solve? M stands for measure. And this is critically important for Lean Six Sigma, is actually using data to drive your decisions, to define your problem. And then transitioning to A and analyzing that data that you have before you enter into the improvement and then the control stage. So let's start by looking at the define, measure, and analysis phase, for which I'm going to turn it over to Alison and Mallory. Oh, no, wait, I'm sorry, one more slide. I'm gonna give you the start. So in January, we formed an interdisciplinary team to evaluate and look for opportunities that we can improve our communication between providers and nurses. This is the Partnering and Communication Optimization team. And so we took two different approaches to learn about our paging trends, which we're gonna talk about in more detail. The first was a survey to gather insights about the current state. What are people thinking about paging? And the second was an analysis of the actual content, quality, and volume of pages that were being sent. The scope of this being hospital medicine and from the division, and then looking at North 6 and North 9 in particular moving forward.
So our first step was to develop a survey for HMS providers as well as nurses on North 6 and North 9. It was developed by the PICO team. The survey contains 7 questions about perceptions of paging using a Likert scale and 1 optional open-ended question on opportunities for paging improvement. Respondents identified their role, MD, RN, or APP, and a typical shift they work, which is to say days, nights, or rotating. It was distributed by email and also posted with a QR code for easy completion by smartphone or via the internet. We had 91 people complete, which was a great response, and 54 of the respondents completed our open-ended question. We had good representation on the survey. We had 34 RNs, 12 APPs, 33 doctors, and 2 others, and we could not figure out what the 2 others were, but we're glad to have them.
So the second approach we took, our second method, was a retrospective quantitative quality improvement study of all the pages sent for HMS teams 1 through 8 for 7 days. So that is the MD and APP paging records were pulled for every MD and APP covering HMS for the dates October 5th through the 10th of last year, that for the date, time, recipient, and message. Our interdisciplinary team reviewed all those pages for adherence to best practices and content and categorized them based on their subject into broad categories. This slide really kind of displays our process in Excel for using 1s when elements were present and 0 when they were not, the subject. And then if all 5 elements were fully present, we consider that a successful page. The paging subjects were broadly labs, meds, vitals, diet, miscellaneous, a change in clinical status, and pain. So as you can imagine, a lot of pages were pulled, a little over 3,000. We were able to exclude some of those based on if they were personal pages, auto pages, consults, things of that nature. An additional 75 when they exceeded the 255 character limit was something we had decided on to exclude. And then on our second pass review, we ended up excluding 50 additional ones based on the first initial exclusion criteria. So all in all, about 1,800 pages were analyzed in the final analysis.
So the first insight we found is on the survey, 50% of staff, over 50% of staff did not agree or strongly agree that the current paging system is effective in providing safe, timely, and effective care for patients. We got a lot of comments on the open-ended, and I think these speak a little bit maybe to people's roles, but definitely show that this is close to a lot of people's hearts and efforts to improve. We need a standard template for uniformity of pages, no matter which nursing unit sends the page. I want nurses to know that I will 100% come to the bedside and see the patient if they're unsure, but I need to know that. Don't guess at labs that are off or small vital sign changes. There are some providers that are not responsive when it comes to paging, and it takes them a long time to respond. The volume of pages is tremendous. We receive on average 70 pages per night and sometimes close to 100. Also, nurses often disregard paging protocol. There's ambiguity regarding whether they are expecting a response or not. I feel like we have to page for silly things like a lab redraw for clotted labs. It would be helpful if there were a way that nursing could text or page providers from our ASCOM phones, and that has become particularly valid in COVID when the nurses may be in the room without all of the communication capabilities that they would normally have. Another opportunity we found for improvement was that less than 50% of survey respondents agreed or strongly agreed that current paging system was effective. Certainly, if there's not confidence in the system, that undermines our ability to communicate well and trust that there will be a good response when things come up.
So our second insight was that complete adherence to our best practice pages is very low. When looking at all 5 critical elements and having those needing to be present, we were only successful with less than 15% of the pages. So 86% were considered unsuccessful. This doesn't mean that these were unintelligible pages and that they weren't able to be answered, but we weren't obviously following our established clinical guidelines.
So back to the survey a bit, about 75% of respondents agreed or strongly agreed that they were aware of the effective paging guidelines, as you can see here. And a similar percentage agreed or strongly agreed that they felt comfortable using the effective paging guidelines.
So our key takeaways, if only 15% of pages contain all the necessary elements to be considered successful, that contrasts of 75% of staff believe they possess general knowledge of effective paging guidelines and confidence in usage. So despite self-assessed knowledge and comfort, there's a significant opportunity to drive adherence to effective paging best practices. Our third insight is that priority indicator is by far the biggest driver of compliance exceptions. This slide kind of breaks down a little bit further each of those 5 elements in our compliance. So 92% of the time, pages have included the sender's name and callback number, and 97% of the time they have a concern. We can definitely do better with name and MRN at 50%, almost 50% compliance as patient identifiers, but that priority label is really only present 32% of the time. That priority label is what drives the acuity of the page. As Chrystina talked about earlier, it sets the expectation of response time and the need for escalation. So the question is, if more than 2/3 of our pages do not contain a priority label, can there really be a reasonable expected response time based on our escalation guidelines?
Less than 50% of respondents felt that provider response expectations were clear, so this shows an obvious opportunity for improvement. About 2/3 of respondents felt that page responses were timely. And again, this is better than half, but certainly it's significant room for improvement, especially if there's a critical change going on. So our third insight, some additional takeaways. Only about 1/3 of pages contain an appropriate priority label. Less than half of the survey respondents indicated that a provider response expectation was clear. And in addition, about 1/3 of respondents felt pages were not being responded to in a timely manner. A significant shift in priority label adherence could drive both patient outcomes and staff engagement and teamwork. So there were a lot of other things that came to us as we went through these thousands of pages. Providers were generally unaware of the expected response times, especially people who may not have trained in system. Nurses were unaware that FYI could be used for kind of low-level requests, so they're not necessarily expecting a callback from the provider. Nurses often include a floor and a room number trying to make things easier for us. And certainly if I'm going to a different floor for a rapid, that's helpful. But if it doesn't list the patient's name and MRN, I may be putting in orders on an incorrect patient. And this is something referring back to Steve's portion on the hospital national patient safety goals and VCU policy, that those are both to be included, 2 identifiers that we specify name and MRN in our policy. Many pages were extremely long and clearly painstakingly written with a lot of detail, but sometimes that was overwhelming and made them more difficult to triage, and therefore the shorter ones were almost always better. There didn't seem to be any difference between please call and please advise in the review of the pages. Many of them were technically correct in terms of containing the elements, but the order was random. And again, this makes it difficult to triage as the provider. And multiple priority labels are sometimes found. So for an example, FYI, blood glucose is 432, please advise. Well, am I not to call back or am I to call back? So there is a confusion with people sometimes using FYI colloquially instead of as a priority label.
So what do we do now? So putting things together, we've defined our problem. There is not confidence by staff that our current paging system is effective in providing safe and timely care. So we've defined the problem. We've also measured it. We've looked at adherence to these best practice that VCU has agreed on, and in the literature we find as well the best practice when it comes to paging. And we see we're not where we need to be. And we've done an analysis and found that the priority indicator is by far the biggest driver of compliance exceptions. So what should our approach be to improve widespread frustrations with paging? Well, I want to say there is a lot more analysis that we could do. We have essentially a treasure trove of information from those thousands of paging records, and really no shortage of ways that we can analyze and pick apart the data. But we think we're at a point where we don't want to stay in just studying. We want to take action and try and make things better. So let's look back at our framework here using the DMAIC framework for data-driven improvement. So the PICO team's entering now into our improvement phase, where we want to implement and verify our solution. So what is our approach? Many of you probably have seen this graphic before, which is the hierarchy of intervention effectiveness. And essentially what it says is that there's a number of different ways that you can try and tackle a problem, and some are more effective than others. So starting at the bottom, you can see that people-focused interventions can be less effective. Things like education and training, rules and policies, reminders, checklists, and double checks. And some interventions can be more effective. Things like simplification, standardization, automation, and computerization, and forcing functions. So systems-focused interventions are more effective and sustainable, whereas people-focused interventions may be less long-term effective, but are critical for change adoption. And I see that participants have raised their hands, and I think we're going to take questions at the end. So please hold on to your questions. I don't want to miss them in your comments, but we'll go through that at the end. And we are hoping to have a significant amount of time for conversation at the end. So back to what I was saying. So this is early thinking from our team, and we'd love to hear the feedback and thoughts of folks as they think through this. But essentially, we believe that initial improvement in paging and escalation expectations can be improved with targeted people-focused interventions. Specifically, the scope of this PICO group would be for hospital medicine as a division and on North 6 and North 9 nursing floors. Now, looking at these different broad buckets of how we can make changes, we will start from the bottom up here. We can look at education and training using the existing resources that we have to increase awareness and understanding. So maybe that looks like nursing daily unit huddles, repeatedly and routinely coming back to training on what effective paging guidelines would be. Maybe that looks like a specifically focused educational session for new nurses coming onto the units, which we've seen tremendous increase really across all of our different units. And for the provider side, the education and training could look like reinforcement of in our staff meetings or in our existing sessions where we go through training. The second bucket would be through rules and policies. Well, you've seen already the existing algorithms of escalation and effective paging guidelines. And so we have those rules in place, or we have those policies in place, but it seems like one thing we can do would be to reinforce them. So is that regularly reviewing them on a floor and making them more accessible and visible and easy to find and spot when you look on the internet, but also like when you're out on the floor. So, and then the next one would be reminders, checklists, and double checks. So our thought is we can deploy real-time reminders to nursing to publicly display examples of pages in high traffic areas, or we can display the escalation policy prominently, as well as the effective paging guidelines, both for the nurses and for the providers themselves. So these are people-focused ideas that we have for improvement and look forward to implementing. But really, we think that building off of initial improvements, longer lasting and more widespread improvements when it comes to paging and escalation expectations could be achieved with systems-focused interventions. So starting at the bottom here, we can look at how we can make this process more seamless. Can we simplify priority? I think it's certainly worth taking a close look at simplifying the priority labels when it comes to please advise and please call, recognizing that in the current state, there is very little difference perceived either by nurses or providers when it comes to that label. Can we implement technology that can confirm a page was read, which we'll talk about in a second? And how about when it comes to automation and computerization? Can we create enduring behavior reinforcement, for example, using learning exchange models, something that everyone is looking at, or we could make so that everyone could look at and to understand and learn what the best practices are and what the expectation is both for nurses and for providers. And then at the highest level of this graphic are forcing functions, removing the opportunities for error. So this would be something like using a drop-down menu on paging applications to require inclusions of essential elements. And what I mean by that is, and this is from the Journal of Pediatrics, actually from 2019, where they underwent a quality improvement initiative on a hospital-wide level over a course of a couple of years to really completely revamp how they approach paging. And you can see what they ended up doing is that force functioning, where you see the asterisks on the left of these were required elements to include in pages, and then gave the text of the page at the bottom so that every page, every time was the same. So really quickly, Alison's going to just say one word because 2021 is the year of EPIC for VCU. So we would be remiss if we didn't mention this.
So just a thought on the technology aspect. We're going to be moving to EPIC, which is forecast for December of 2021. EPIC comes with a secure chat function, which is a different variant of paging, which allows users to send HIPAA-compliant text messages from desktop computers or mobile devices. It indicates the status of a message. So somebody sending a page, for example, can see that it's been read. It can be used for one-to-one or group messaging, and it allows parts of the chart to be tagged or pictures to be edited in some versions. Again, there's multiple versions out there. As we potentially shift the platform with which we communicate, effective communication practices are all the more essential.
So we've given you our initial thinking when it comes to improvement efforts, our improvement phase. But we would be remiss as well if we didn't mention the most critical aspect of any improvement project, which is the control phase. Because we can do all this work right now, but if we don't control and make sure that this is sustainable, 2 years or next year, I'll be presenting this exact same presentation for you. So how are we anticipating and looking forward for the control phase? Right now, we have a couple ideas what that might look like. Does that look like, well, we are planning on resending out that survey after our improvement phase to see, have we sustained the changes? Are our pages perceived as being more effective and better for patient care? And then we can look back and pull more records and do subsequent paging audits for adherence to those best practices that we've outlined for you. So in conclusion, we think we can improve our communication and paging. And really, this is a win-win-win. Certainly a win for physicians and APPs with clearly defined expectations and standardized pages, which will help them to appropriately triage. A win for nurses with clearly defined escalation and formatting. They can better articulate their concerns, but most importantly for patients to provide safer care. And can't overemphasize that this is a team effort. Trust, respect, and humility are essential as we go through this quality improvement process. So with that, I want to thank the many members of the PICO team. That's Jen and Lindsay, Tim. Very special thanks to Emily for very, very strong leadership project management-wise. Mallory, Chantal, Chrystina, and Alison. Also want to thank the quality and safety leadership for the department, Georgia McIntosh, Haim, Mary Helen, and Kristen, for their continued insights and guidance. Also thanking Alan and Jessica for their leadership for the Division of Hospital Medicine, and then huge thanks also to Donald Smith, who went above and beyond getting us these paging records and providing IT support. So with that, I want to open it up for comments or questions, and also say that if this piques your interest or you have feedback that we don't get to, please don't hesitate to send those to the team. Okay.
There you go.
Okay, so we have a couple questions. Why don't we use 10-digit phone numbers for pages?
So there was a transition from some of the unit numbers or some of the shortcut numbers for the nurses' ASCOMs previously. So the real move from 5 to 7 took a while, and there has generally been pretty good adherence to that now. I agree that for those of us who are using a cell phone as a pager, that can be helpful. But knowing that you're calling back an 804 number, it's not a huge burden necessarily to put that in, but that could definitely be a best practice thing that could be looked into. Definitely not thinking about doing like huge modules, but definitely adding something that's refreshed periodically, because certainly a lot of people had perceptions that varied on the response times and things like that, that kind of fades when you've been here for a long time, or certainly for new providers coming from out of system, it's something that maybe haven't heard, or they sort of breeze through when they're being onboarded. Certainly with a lot of the new nurses or travelers or things that are onboarded quickly too, there's a deficit in recognizing what those priority labels mean.
So the next question is, does it matter what order your name and number goes in, first or last? And so, if we follow the document created on the intranet, it would suggest a specific order. I can tell you that in review of the page, we saw everything. I mean, some are starting with a number, some are starting with a name. And so, the reality is that there isn't a best practice of an order between a name and a number. But what might be best practice is reducing the variability. So name, number, name, but doing it the same way every time, and trying to achieve consistency really across the board. So that we know what we're looking at, we know what to expect as providers, and then we can, it makes things all the more easier to respond. I saw someone a couple people have raised their hand. I don't know how to, what to do about that, to be frank.
Are people actually able to speak to us, or is it just through chat?
It is just through chat. So if anybody does have any questions, please either use the Q&A feature to ask the questions or ask them through chat.
Cool. So any other questions or comments? I know that people did raise their hand, but
maybe give people a couple minutes to type it in the.
Yeah, we'll give you a second to type it. Or okay, so this is from a question. The last part of a page can get cut off if page is too long, so should be first part FYI. You want to talk about that? Like what your thoughts about that maybe?
Yes, so that does happen often, that pages do get cut off. And so the hospital in its effective paging guidelines does ask for that priority label to be the first thing. And is that what it's asking there?
I guess so. And I think, but one thing that we learned in reading through all these pages.
Yes, I'm sorry.
Yeah.
Go ahead.
Is that there are some pages that are sent, we had to exclude like 50 pages that exceeded the limits of the software to pull pages in the first place. And it's like the length of a tweet or something. And, those pages every single time contained valuable information, but could have been pared down. And ultimately, when we're thinking about the perspective of who's receiving the page, want to focus on maybe the most important parts that you want to communicate. And if a page is going to be a paragraph long, then maybe there's that could be a trigger that this might need to be some kind of communication, conversation.
Right. Well, I think Mallory put it best when we were going through these, saying that although there's great information in a lot of these long ones, if it's getting to be that long, why not just call?
there's another comment here. Will this survey become hospital-wide to other teams and floors? This is very important. How can bedside nurses help as well? That's a great question. And I can tell you that part of this team we're working on North 6 and North 9, which are the most common, or the typical hospital medicine, two of typical hospital medicine floors. And we've got some truly fantastic nurses that have partnered with the providers. I think that there is, so, in terms of data, can only speak about hospital medicine. I do believe that there is likely a high degree of generalizability of our findings beyond just hospital medicine, but I agree the survey was specifically for hospital medicine, and the data that we pulled on paging is specifically hospital medicine. But I don't think that there is. I don't think this is limited to our division. And so as we make improvements and changes, our goal has been, and our thought has been, that this is something that we can scale. So starting on these floors and then looking in the future to scale. So I have another comment here from Alan Dow. It seems the other half of the challenge is matching the demands on the hospitalists or residents with the needs of patients. Any ideas how to communicate better with nursing when a particular doc is tied up with patients? You have any thoughts?
Well, so certainly, better use of this and making it easier to triage does make it easier to respond to things that are more urgent quickly. That's definitely something that we saw with the order being more consistent and using the priority tags correctly. Moving forward with the secure chat, maybe the idea that participants could be texting each other back and forth. It's certainly easier to say, hey, I put in the Tylenol, let me know if the temp doesn't come down, rather than calling back, waiting for somebody to respond. Maybe they're tied up in with a patient, because the nurses certainly are very busy and having to cluster care and things like that. So having been on the other side of the pager, I can appreciate trying to cluster your care and having another patient load, and you're kind of held up in what you can do until you hear back from the provider. So,
yeah, I think that's why the priority label is so important, because from my perspective as a nurse, if I send a priority label, I know what to expect from the team. And also if they're busy, then they know, like I've had plenty of times where Al, I've paged you and you'll call me back and say, I'm busy, I've gotten your page, I'll get to it, things like that, which necessarily doesn't mean that I needed a call back, but just the identifying that you received the page was important. And I think just for the nursing wise, for them to just be aware of all the elements of the page, and just knowing also where to find this information on the internet and being able to show that to people that are onboarding with the new grads and the travelers and everybody, so that everyone can be on the same level, and also so that it sets the priority for what you're expecting when you page somebody.
But also, and I don't want to miss this, is that we have this escalation algorithm, and the hope would be that a nurse would not have to escalate, that if you are an intern that can't respond to a page and you see, oh, this needs to get responded, you're go ahead passing that off in real time to your resident and up the chain, or same thing with an APP passing it to their physician. And we know that that does happen, and it happens probably most of the time. But how do we look at things and make it happening increasingly?
Yeah, and I would also say this was kind of just the step one. This was a lot of work in a really short amount of time, but we have so much data. And something that I was really excited about too is we had to really start here before we kind of went anywhere else. But we definitely had data on the timeframes that nurses are sending pages, and there's some work to be done there too. And I think that that would actually also help answer Dr. Dow's question about the needs of the patient, because there could be a way that we're reducing pages during certain times that would make it easier to hopefully be able to respond.
So we got a question here. How do you recommend giving feedback to nursing if the protocol is not followed? Well, I'll say in the current state, you'd be providing a lot of feedback, right? I mean, 85% of the time you would be providing feedback. So I don't know if I think it's very challenging right now until we kind of spread the word in a better way and we improve adherence, because I don't think it's realistic or helpful to, for 85% of the time communicating that the protocol is not followed. But I think that this can be tricky to provide real-time feedback. And no matter what, I think is recognizing that we are all advocating and working on behalf of the patient. And when a nurse or provider or anyone is sending a page, they're doing that, we hope, for a reason, and so just keeping that collaborative approach, I think, is critical. But as for specific verbiage, I don't know that we're at a point where it would be realistic to really be providing that consistently.
Certainly, there are deficits on the provider side too. Like a quick example, we had a new provider to the system who was very frustrated with the volume of pages they were getting. But when I reviewed them with that individual, a lot of them were FYI, and I was like, well, these nurses aren't expecting you to do anything. They're just letting you know about something. So there was a lot of relief. But I've gotten like a second page on an FYI where someone's using, again, like using colloquial or inappropriately the FYI. I've given feedback, but I'm also, it's kind of my second time going through paging on a committee, so I feel like I have some expertise to give it back. It's difficult to give feedback without trying the intervention, at least having some time for that to roll out.
Yeah, we got another comment here. Eventual initiative with addition of secure chat for provision of texting capable phones to nurses so as to avoid having to text NDs and APPs from laptop or desktop only. I think this is asking, are nurses going to be carrying smartphones, which they already are, obviously in their own phone. And I cannot speak to definites, but I do think that is a change that's likely going to occur. I'm not the one who's making the decision, but I do think I've heard at least rumors that is the direction in which we might be moving for nursing, and which would allow for more of the texting communication. But I will also say that texting it can provide tremendous benefit potentially, but it can also, there's
still miscommunication can still occur.
Yes, absolutely. Thanks.
Yeah.
All right, we have another comment. I also wonder if this is more common on HMS floors due to familiarity between nurses and physicians. And that's a great point from the commentator. I think I can only speak to the data for hospital medicine. The survey was sent to the Division of Hospital Medicine, North 6 and North 9. But I will say that the paging records were pulled for all of the division, so teams 1 through 8. And so that contains patients, a lot of patients on North 6 and North 9, but tons of patients C3, C4, all over main hospital, North 1, North 2. And so when we look at the paging records, they are to hospitalists, yes, but they're from all over the hospital. Okay, and we have a comment from Tonka. The plan with Epic, yes, later this year. Nurse ASCOM phones will be replaced to iPhones, so that's awesome. Hopefully it'll be the iPhone Pro with the 3 lenses for pictures. Any other comments?
We have a few more further back on that.
Oh, I'm sorry.
On the left, if we can go up a little higher. So it was asking, is there any data on the use of the senior physician on call and the escalations of concern by the nurse? The biggest question is when the senior physician should be paged, if there's ongoing communication with the physician, but without a response that meets a level of concern by the nurse. And Chrystina, that's...
as far as I'm aware, there wasn't any data in the pages that we pulled about the physician on call.
No, and I'll say that it was added to the algorithm of escalation of care in February of this year. So that's new to the algorithm. So I think it would be premature to speculate. I think that is I think, there's maybe this, that nurses should avail themselves of that use, but also there probably is hesitancy in availing themselves of the senior physician on call.
That is a last resort. Yes.
And I think that should be a last resort. I think that
but I will say that the communication, because of the increase in serious safety events, there is a lot of education to nurses in the most recent history of making sure we're escalating appropriately and not waiting if there is a concern. And obviously there are concerns for the hesitancy, but there has been a big push to escalate if appropriate, if you're feeling it's appropriate, and to not hesitate if you do believe it there's something serious.
And kind of relevant to escalation, but Tanya, to address your comment there, the best practice when paging, you don't know who you're speaking with, whether it's the attending resident or intern. There has been some improvement in recent years due to some prior safety events of trying to identify who you're paging by the pager. But again, when you are going to page somebody quickly in an emergency, it's kind of easy to miss that. I'm often going back and saying, oh, wait, who did I page from surgery or something like that, right? I'm not sure who I paged. I do think it's appropriate, especially if you have concerns about the response or maybe not getting feedback that's appropriate, to get someone to identify their role. We talked that all of us across the board have some hesitancy with escalating sometimes, even when it may be becoming necessary, and it really shouldn't be. I think it's maybe foolish to pretend that there's no hierarchy in medical education practices, but at the same time, the attending shouldn't be a scary person to contact, or it shouldn't be a bad thing to have to speak to the attending. And likewise, for an APP or an intern, we don't want to feel like or a resident, we don't want to feel that we're being punished because somebody does escalate. It's a team effort, and it needs to be a multidisciplinary team that's involved.
I think patient-centered, right? And then maybe opportunities for a reflection afterwards, if that was the right thing to do. But if you've got the patient in the center of it, then
It changes.
yeah, exactly.
I agree.
Thank you.
Heather Masters has a comment: as senior physician on call, I rarely get paged for this type of thing. That said, I will expect that the attending of record has been called, discussed with first. But if that has happened and still no resolution, please page the senior physician on call. Thank you.
So we have done that on my personal unit. We have had to do that at least twice in the past couple of years. Again, it is a last resort. And of course, we have at that point exhausted all of our means going up the hierarchy and talking to the physician or the attending. And that is basically, it was a nurse-driven thing where we thought we had exhausted all of our resources and we still weren't getting the feedback or the action that we wanted. And that's when it was escalated.
We have a comment here: any electronic solutions for physician or APP to easily identify RN ASCOM number for patients. That is in what is it called? Teletracking, but it's obviously not always utilized. Yeah, a lot of clicks.
Sure, and it's something that might change with Epic too. So Dennis, I think you're aware of with RAMs, when you sign in there, you have the option to kind of sign in for the day to the pager, which we typically don't do. We're just printing them for reference. But with Epic and looking at secure chat, it would be people kind of signing into that on the nursing side and on the provider side, so you can kind of see who you're going to be talking to about that patient when you're going into the system. Ideally, it'd be interesting to see it in real time.
And it looks like Dr. Syme raised her hand. I don't know if we have the potential, so she can.
Yeah, thank you for this round. And I just wanted to make a couple of comments. I think you've done a tremendous job in identifying and using all of our resources and all of our colleagues to analyze the problem and come up with some solutions. So I'm incredibly proud of the work you've done here. I think it's really important. There has been an increase in serious safety events in the hospital. And of course, it's the biggest department and we take care of a lot of the patients. We're involved in them. And I think this is exactly the kind of approach, multidisciplinary approaches, and how do we do things better. So, I'm just delighted to see this. And the other thing, please never be frightened to escalate. We are all on the same team. I do inpatient attending. I'm always happy to be called personally. And I know that my attending colleagues, it might be frightening to think you're calling the attending. You should never be frightened. That's our problem if we're frightening you. So I never want people, same with the senior physician on call. If we need to call people, we just call them. It's about our patients. No one's doing it because they're trying to be irritating. We do not think any less of you for doing this. In fact, we're often proud of you for escalating things that we didn't know about. So, please don't look at that as a negative. I see escalation as a positive if it's needed.
Thanks for those comments. So I think we're just about out of time. I don't see any other comments, but we're good. Awesome. Well, thank you everyone for joining us and participating. And again, don't hesitate to reach out with email. And thank you, Dr. Syme, for your comments as well. And we look forward to seeing improvements with this regard. So take care, everyone.
We got to figure out how to get some scholarship out of this too, because that's a great thing.
Okay.
Yes, ma'am. Thank
Working
you.
on it. Yes. All right. Thanks, everyone. Take care.